Hi, and our final topic today for this course, we're going to be talking about psychotherapy. Now, psychotherapy is kind of just a generic term to refer to any attempt to help a person with a mental illness or a mental disorder. And so, attempt is a key word. Doesn't mean succeed because there's many avenues of psychotherapy that are potentially not helpful. In particular, what we find is that, if you recall from the last topic, we had said there's three main ways to think about psychological disorders. And we said the supernatural view, the psychological approach, and the medical model. Okay, so these three sort of competing, overlapping or something. And so the view that you take on mental disorders is often going to guide the type of psychotherapy that is going to be most effective or appropriate. So you find way back when, during the time when mental disorders were considered to be completely and utterly supernatural. So it's like demon possession or something like this. And so we can see in the top corner here a tool which is used in ancient times, and not even all that ancient times. And it's for what they call trephining. And it's basically a drill that is used to drill a hole in the skull. Because if you believe that a mental disorder is caused by demon possession, then a hole in the skull will, in fact, release the demons. Okay? So, probably not all that effective, although in some cases where, say, for example, swelling in the brain can cause some strange hallucinatory, some crazy symptoms. And so, to the degree that drilling a hole in the skull can relieve the pressure that's built up, then, yeah, I mean, it actually probably had at least some degree of effectiveness in at least some cases. But other early treatments were, if you believe that the body is possessed by demons or supernatural creatures or something, then the goal is to make the body so undesirable that a demon would not want to live there. So they would take the person with a mental disorder, perhaps start to electrocute them, spin them in chairs, throw cold water on them, all kinds of things to make the body so undesirable. The key word to psychotherapy was attempt. Okay, so these quote therapies did in fact have the right idea at heart, but they were guided in completely the wrong way. So we can break down three main categories that might be used today. Okay, we can talk insight therapies, behavior therapies, and biomedical therapies. And clearly, the biomedical therapies are predominantly from the medical model, whereas the insight and behavioral therapies come much more from the psychological approach to mental disorders. With insight therapies having their roots in Freudian type therapeutic thinking, usually, but humanistic as well, whereas behavior therapy is being rooted much more in learning theory. We're talking like B.F. Skinner, Ivan Pavlov, this kind of, John Watson in particular, by the way. So, often we find approximately 15% of the people in America, in fact, are involved in psychotherapy, with anxiety and depression being the two major complaints that people have. Not a surprise. Of course, as we had discussed, especially once you get cross-culturally, people vary in their willingness to seek help. All right, so obviously women are more likely to seek help than men, but cross-culturally, like in Asian societies, the very word mental disorder has such an incredible social taboo stuck to it that people in Asian societies, there's really only one solution for somebody with a mental disorder, and that's to put them in the back room and don't talk about them, all right? So clearly there's some huge variation in this willingness, and demographics, of course. So many people that need therapy don't receive it, partly, as we say, it's this willingness, but a whole lot of it is time or money involved in the process. And perhaps you keep up with the news on this issue, but there's a huge controversy with insurance companies and what insurance will pay for mental health treatment. And we find that, despite the successes of Obamacare did not really do a great job addressing mental health treatment. So most insurances will have a lifetime cap for medical procedures and a lifetime cap for mental procedures or psychotherapy type procedures. And these are separate caps, and clearly the psychological treatment cap is much lower. They'll also have annual caps on that psychological stuff. And so all of a sudden, you've only got 10,000 a year or something maximum. And so we find that the insurance companies are driving in many ways the treatment process. Well, there's many kinds of people involved in the psychotherapeutic process. We could take the top extreme end and look at a psychiatrist. A psychiatrist is somebody that first receives a medical doctorate, so they are an MD, and then they specialize after that in psychological disorders. Clearly, psychiatrists are far more likely to, again, focus on the medical model. Well, obviously, because they're medical doctors. And so they're much more likely to implement drug treatments than others will. And in many states, it is only psychiatrists that are allowed to prescribe medication. Include there was been a push from the American Psychological Association to create laws to allow clinical psychologists, which are doctorates, but they do not have a medical degree. They are doctorates and they have this, but many states won't allow it because the American Psychological Association is pushing for clinical psychologists to be allowed. The American Medical Association is pushing very hard against such a thing because they say, oh, it turns out that a clinical psychologist doesn't have the overall general training in medicine to understand perhaps drug interactions and what will happen to other parts of the body. Okay, so potentially legitimate. Well, it turns out that a psychiatrist is much more expensive than a clinical psychologist as far as going there. And so, I mean, imagine these numbers. You've got $500 an hour to go to a psychiatrist, okay? Remember that $10,000 annual cap that you have on mental health treatment? That puts you at 20 visits per year to a psychiatrist. Let's say a clinical psychologist, $200 an hour. All of a sudden you've got 50 visits. That's one per week, and you're still in your cap. So clearly what's happening is that it's cheaper, less expensive to go to a clinical psychologist, but you're going to get a different kind of treatment. Clinical psychologists do implement some drug treatments, there's no doubt, but they're more likely to fall back on more of these psychiatric treatments, the insider behavioral approaches. But what you find is the insurance company in all of this is pushing really hard to allow the prescription of psychiatric medications down. Okay, not just a clinical psychologist, but a counseling psychologist. Not just a counseling psychologist, but a master's degree in counseling. It's like, no! But they're trying to save money, right? Because clearly one visit to the psychiatrist to get a prescription refill costs the insurance company a whole lot of money and they don't want to spend it. Okay? So we find at the opposite extreme of a psychiatrist, you could go to, say, for example, a pastoral counselor, for Christian counseling or something. And so if you're having perhaps problems in your marriage, it's still psychotherapy, and you would go to, say, like I say, maybe a minister or a pastor or something of this nature. And at the most top extreme, if you're having schizophrenia, don't go to the pastoral counseling. Okay, that is not the solution. Schizophrenia is really the job for a psychiatrist. Okay, but there's a whole range of disorders between full-blown schizophrenia and marital problems, right? And so clearly there's a wide range of people that fall into the psychotherapy or helping professions from the top to the bottom, and they're used for different purposes. So insight therapies, verbal interactions intended to enhance a client's self-knowledge. Okay, very briefly, let me describe the justification or background for psychoanalysis. Going to have to pull your brains out to topic 2, I think it was. And so if you basically recall, what happens is you have an id. Remember, the id is on one shoulder saying, gimme, I want it, right? And the superego's on the other shoulder going, no, 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 that's naughty. And the ego sits in the middle and tries to satisfy both the demands of the id and the requirements of the superego. Okay? So now, if the ego sometimes can solve the job. Remember the example we were like, the id goes, I'm hungry, give me, and smash them in the face and steal their candy bar or something. And the superego goes, no, 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 we don't hit people and we don't steal, right? So the ego goes, I got it. I'm going to reach into my pocket, pull out a dollar bill, walk down to the vending machine, get a candy bar. All of a sudden, the id is satisfied and the superego's demands are met, okay? Sweet. But in a lot of cases, if you recall what happens, there is no solution. Remember, we had talked about the Oedipal complex, which is when little boys around 4 years old begin to desire mom. And if you recall, what's happened is, the id's like, gimme, gimme. And the superego goes, no! And the ego's going, I ain't got a solution. What am I supposed to do here? Okay? And so what the ego does is uses defense mechanisms. Remember, we had talked about a variety of defense mechanisms, but the one overall defense mechanism that described them all was repression. And so the ego says, okay, oh my God, I'm feeling so much anxiety, right? Anxiety is what you feel when the ego is having a problem dealing with these two demands. So in order to deal with that anxiety, what does the ego do? Repress. Shoves all that crap down below the level of the consciousness. Problem solved, says the ego, right? But now, according to Sigmund Freud, just because, and remember the analogy of the iceberg, 10% of our personality is above the surface and 90% is below. And so we're only aware of 10% of what's going on, but that other 90% that's down there below the surface can create issues. Let's say, for example, what might happen is, according to Freud, I'm just giving you Freud here, that this repressed thing, this repressed desire for mom, it doesn't stay down. It has a tendency to rise to the surface, and the ego has to hold it down and hold it down. And so what happens is, imagine that a child has this anxiety, this repressed thing, and so it's starting to come to the surface. And what a child might do is have a tic. And so the tic, according to Freudian, I'm just saying Freud, the tic is a visual representation of that underlying conflict, okay? So every time that conflict is about to reach the surface, tic. And that is the ego's way of sticking it back down. So now, the point is, all of this stuff below the level of consciousness manifests itself behaviorally across our lifetime. And so, according to Freud, many of our maladaptive behavioral patterns are in fact the result of these unconscious things. So in traditional psychoanalysis, and again, keep in mind that the ego's job is to hold that stuff down. That is really what it is designed to do. And so according to Freud, the basic idea of psychoanalysis is to get at those underlying things that are down there. In other words, the idea is it's like ripping off the biggest Band-Aid you can imagine. It's like just, or an emotional vomiting, just whoosh, get everything out at once. It's going to be incredibly painful. But guess what? Now that it's at the surface, you can deal with it, okay? It will no longer manifest itself, in these behavioral ways, okay? So this is the basic conception of psychoanalysis. And so now let me talk about perhaps some of the words that Freud might use. Keeping in mind, again, that the ego's job is to actively hold down these things underneath the level of the consciousness. And so according to Freud, what you need to do is find a time when the ego is weak. Okay? Let's say while you're sleeping, the ego does not have as much strength, and so these repressed urges will start to manifest themselves in our dreams. Okay? So according to Freud, one way that you can perhaps get at all the crap that's down there below the level of the consciousness is to analyze a person's dreams. Okay? And so he talks about, interpreting. The job of a therapist, according to him, is to interpret those evidences from this. Another way you might get the ego to relax is you might do free association. So you might be just like, all right, I'm going to say a word, and you say the first thing that comes to mind. Table, chair, window, door, picture, book, okay. Monster, mother. Whoa, 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 dude, look at that. And so now the therapist's job is to interpret that response, to say, whoa, wait a minute. The first thing, once we were able to get you in a relaxed state of mind, you released what really was down there. But at the same time, part of the interpretation is to interpret resistance and transference. According to Freud, transference is the idea that the client or patient will transfer some important relationship in their life into the therapist's office. And so the relationship between the therapist and the patient is insightful, according to Freud, and should be interpreted. And at the same time, resistances, when, say, for example, the patient is just giving a free run on everything that's going on, and there comes a point where I've noticed that you just don't talk about your father. Is it possible? And so a resistance is that area that people are avoiding. All right, so client-centered therapy and BTW. There's lots of versions of psychotherapy. There's psychotherapy is the word that is used to. It's whatever. Psychoanalysis is a technical term. I bite my tongue. So a second version of psychotherapy would be client-centered therapy. And so unlike, in Freudian view, the people seeking therapy are patients. In more of an insight approach, Carl Rogers being the originator of much of this stuff, they're clients, okay? Because patience implies that somebody's broken. Clients are just simply having a problem adjusting. And so they emphasize a supportive emotional client. And so what they do is they pull the information, client-centered therapy, often called humanistic therapy, is really rooted in Abraham Maslow's hierarchy of needs that we talked about. And we had said, you are like an acorn when you're born, okay? And this just comes directly from Maslow. You're like an acorn when you're born. You have a purpose. Your purpose is to become an oak tree. But what happens if we take you, an acorn, and we throw you into a parking lot, okay? You're never going to become and fulfill your purpose. And according to Carl Rogers, in a lot of ways, if you're born into a home that has some very maladaptive adjustment patterns, well, then you're going to be like that acorn dropped into a parking lot. You've got the potential to be an oak tree, but your environment is all screwed up. Okay? And so according to Carl Rogers, the goal of the therapeutic relationship is to provide that dark, rich soil that is necessary for that acorn to bloom into an oak tree. And so it's an interesting idea. The therapist is non-judgmental. They're genuine, show empathy, unconditional. I understand you. I feel your pain, and I mean this is where I understand what you're saying. This is where this comes from. Group therapy, on the other hand, and again, you can have lots of you could be psychoanalysis, though I think probably, client-centered would work best for group therapy. But what happens is that, again, we've got a situation where, unfortunately, both insurance companies and financial limitations are pressing on people's choices for therapy. And so what you find is group therapy is cheaper, right? It's several clients at the same time. Now, don't get me wrong, a lot of times group therapy is a choice because of money and monetary concerns or insurance limitations, but there's definitely some particular mental disorders like post-traumatic stress disorder, for example, where group therapy seems to in fact be far more effective than individual therapy. That with post-traumatic stress disorder, it's the act of helping others that seems to be helpful to the self, okay? So there is something there. Well, another version of group therapy would be family therapy, but that's a little bit different because it's not 5 separate clients, it's one family. If you go back to Abraham Maslow's idea, or Carl Rogers, listen to me, Carl Rogers' idea right here, that you're like an acorn that happened to be dropped into a bad environment, Well, maybe the best way to deal with that environment is to bring that environment in and talk about the family dynamics. Okay? And so the individual will be able to achieve their purpose if the family is providing the support and background necessary. Look at that. Advantages of group therapy. Their misery is not unique. Social skills. Yeah, as we said, some problems are actually better in a group environment. Are they effective? Well, inside therapy, there's such a broad range. It's kind of too general of a question. Um, Therapy seems to be more effective than no therapy seems to be, but it's not. And some therapies are actually very counterproductive. In particular, false memory syndrome. That is to say that sometimes, and I described this in the last topic when I talked about dissociative identity disorder, and I said it is my belief that most of the people that have dissociative or claim to have dissociative identity disorder, it's really a product of the therapy itself, that it emerges in therapy. And so in another way, there's been a lot of situations where false memories. People go to therapy and they're just troubled and they don't know why, okay? And so, come back to a Freudian perspective, you're troubled, you have these behavioral problems, but since you don't have access to the unconsciousness, you don't know why. And so sometimes what happens is that the therapists will help people to recover memories that will explain the behavioral problems that they're having. But there's been oh so many documented cases that show that the memories that were recovered are just a load of crap, okay? And there's been cases, like say one when I lived up in Springfield, Missouri, a patient went in. Again, she was troubled. She was post-adolescent, early adult, and she was just having a general set of problems, nothing real specific. And so all of a sudden she was put under hypnosis, right? Because again, from a Freudian perspective, if you can make the ego strength weak, get the ego strength down, that can allow these repressed things to come out. And so under hypnosis, right, the ego strength is really low. And so guess what happens? She comes up with his memories, and she now remembers her father, who was the head of the largest, he was the pastor of the largest Baptist church in town. So she recovers this memory of her father abusing her, physically, sexually abusing her. But she remembers, oh, Dad brought in all of the elders from the church, and it was a giant blah, and she just goes through this, and I mean, she publicly confronts her father. It's just really big. And then later on, she ends up going in for an annual checkup, and she's told by the physician, you're a virgin, okay? I mean, you've got every evidence of being a virgin here. And it's like, whoa, wait a minute, that does not mesh with what she came up with, okay? And once the damage was done, the damage was done. You can't undo it. So here's this next question, or going back to the question, does psychotherapy work? And we can take a look here, and you can see on the blue line, the blue graph there, remember there's a lot of variability in this stuff. We see the average untreated person there in the center of the left curve, and the average patient client after psychotherapy on the right curve, the orange one. And so we can see that yes, there is. And of course, there are some people that had psychotherapy that are worse than untreated people, and some people untreated that are better than. And so yeah, I mean, I'm personally, I'm a skeptical one. I really believe that some days I get up in the morning and my ankle hurts so bad. I'm walking, I swear it must be broken or snapped or something. Inevitably, you know what happens 3 days later? It goes away. What happened? I don't know. Okay, and so it is my opinion that the majority of things that arise just go away. That's the natural state of the body. And so in some ways what happens is, let's say somebody is in a depressive state. They go to therapy, and then they're not in a depressive state. And so they swear up and down therapy worked. And it's like, or it would have gone away on its own, right? Okay? And so there's an awful lot of that going on behind the therapy, okay? All right, so behavioral therapies. Behavioral therapies are a little bit different. They're, as I said, based on the work of John Watson in particular. And so behavioral therapies take as their basis that the majority of bad behaviors that people exhibit are the product of bad learning, okay? And so the idea is that, according to John Watson, his basic conception of behavioral therapy was anything that can be learned can be unlearned. Okay? And so if we believe that the behaviors that you manifest or exhibit are the product of bad learning, then, I mean, remember I think I had talked about this example, you've got little Billy and he stands up in the middle of the class and the kids laugh. So Billy is being rewarded for standing in class. So stand followed by reinforcement. And so Billy increases his standing in class behavior. And so it's quite clear from this perspective that this particular problematic behavior, Billy's in the classroom, is a product of simple learning principles. And so anything that can be learned can be unlearned. And that's really, really what it comes down to. Systematic desensitization is this idea right here, for example. What's going to happen is the client is going to, let's say here's one that's somebody afraid of spiders. And so they're going to say, okay, build a hierarchy of your fear. And it's like, okay, the biggest fear I could possibly have will be a tarantula crawling on my arm. Okay. Let's bring it down in gradual steps. Okay, at the smallest perspective, I see a picture of a spider. Okay. Then what? Touch a picture of a spider. Okay, then what? Have the presence of a rubber spider. Okay, then what? Touch the rubber spider. And so you can kind of get the idea. You're going to go through a whole series of steps towards the full-blown anxious phobic reaction. And meanwhile, you're going to teach people, because here's the problem. This person has come to associate the presence of spider with anxiety. Okay, so that's the learned association, spider anxiety. So in the presence of the spider, while you first start with the picture of a spider on the wall, let's calm down. Now, what we've done is countered that association. Previously, the association was between spider and anxiety. I now have countered it and now have picture of spider and relaxed. Okay? And so at each continual step, you just wait until calm has emerged so that you can replace the association. Behavioral therapies are often called counter conditioning. To the degree that conditioning refers to learning, counter conditioning refers to reversing the learning. Okay? Some other ones might be aversion therapy. Here is aversion therapy in action. Well, here. So what happens in this case is, let's say, for example, there might be a drug which, when combined with alcohol, creates incredible nausea. And so what happens is that, you put this drug in the alcohol, people will drink the alcohol, and instead of it leading to the pleasant reaction, it leads to the aversive reaction. So you're simply reversing the associations again, counter. Social skills training, modeling and shaping. Often, what you'll do is let's say you've got a child that is incredibly fearful of dogs. So what you might do is bring in another child, and then the child will then play with the dog. And so what happens is now the child with the phobia of the dogs will view somebody similar to themselves interacting with the dog without the presence of any fear. And if you recall, I had mentioned at one point about the kids and the broccoli and how their peers would influence them, and it's the same kind of a way. If you want this type of a modeling to be most effective, the model themselves need to be as similar as possible to the person involved. Cognitive behavioral treatments. There's a funky word in the world of therapy, and that's it's so funky I can't even remember it. It's stuck in my brain. It's eclectic. Eclectic refers to the idea that many therapists are, quote, eclectic, which is to say they're not behavioral per se, they're not insight per se, they're not biomedical per se. They sort of bring everything together based on the situation. And so cognitive behavioral treatments is a version of an eclectic form of treatment where you're going to bring together cognitive and behavioral mechanisms. So you might say, for example, You might work on a behavioral thing such as exposing them to a spider while at the same time breaking down the rationale in a cognitive way. So why would you be afraid of spiders? A spider has never hurt you before or something of this nature. Biomedical therapies, okay? And there's a couple of versions, or a couple of angles on biomedical therapies. Psychopharmacology would be drug treatments. And we had briefly mentioned, say, for example, in the last topic, we had said, if there's somebody that has depression, then I predict they will probably have low levels of serotonin. If somebody has low levels of serotonin, I would predict that they probably will be exhibiting symptoms of depression. So this is correlational, right? But the idea is if low levels of serotonin are involved, then hey, I have an idea. Why don't we do things that raise the level of serotonin? Okay? And that's really what an antidepressant would be. Look at me, I have anti-anxiety and antipsychotic here, but an antidepressant would be raising levels of serotonin. Antipsychotic, remember we had said if somebody is exhibiting symptoms of schizophrenia, I predict that they probably have high levels of dopamine. And if people have high levels of dopamine, they're probably exhibiting symptoms of schizophrenia. So antipsychotic drugs are really designed to deal with this problem. There's too much dopamine. Okay? All right. Where is it? There you go. Oh, there's my antidepressants. Okay? And so there's a variety of ways that you can make antidepressants work. You can, I mean, literally mimic serotonin, but the most common is SSRIs. And SSRI stands for serotonin specific reuptake inhibitor. One of the processes in the act of neurons communicating with each other is one neuron sends out a neurotransmitter, the neurotransmitter causes the second neuron to fire. After that second neuron fires, that neurotransmitter is sucked back up into the first neuron and destroyed. Well, SSRI, what it does is it prevents that destruction. So neuron 1 sends out serotonin, neuron 2 fires. The serotonin remains in the synapse between the two neurons now. That's what an SSRI will do. Okay? Mood stabilizers would be used for bipolar. Antipsychotics, this is an interesting point right here. All psychiatric medications will have some side effects. Unfortunately, these medications have not been specifically targeted. They always do other stuff. And so the antipsychotics, for example, can create drowsiness, constipation, tremors, impaired coordination, and if taken for too long, tardive dyskinesia. And tardive dyskinesia is an uncontrollable reflexive disorder. It's basically a loss of motor control. And so somebody with tardive dyskinesia will just be sitting there and then just and their head will shake and their tongue will come out and they'll make weird sound and they can't stop it. Okay, so we find that patients that need psychiatric medication sometimes are resistant to this stuff simply because the side effects can be considered worse than the disorder itself. So here we got a graph here, and this is state and county hospital residents in thousands. Fact is, to this day, the majority of the people that are in psychiatric hospitals are there because of schizophrenia. That's the main cause. It always has been the main reason. So we can see right here, moving from 1900 up to 1950, this is residents in mental hospitals. And then all of a sudden, you see the dashed line, antipsychotic drugs were introduced. And we can see a plunge right there. But when we see that plunge in residents in mental hospitals, we also see a spike in homelessness. Okay? So a whole lot of these people that were released, and this reminds me of Larry Robeson from the last topic, just because they're released from a mental hospital doesn't mean that they have the social skills or social support to stay that way. Some people, in particular clinical psychologists or counseling psychologists, might have a very low opinion of drug therapies because they might view drug therapies as nothing more than a band-aid, okay? That you haven't really addressed the problem at all. You haven't cured anything. You've simply got the symptoms under control. Some people might say that the goal of psychotherapy is not to get symptoms under control, but to solve the underlying problem so that the symptoms will never emerge, okay? And there's something to that, okay? Maybe psychological medication combined with psychotherapy, insight therapy might not be a bad idea, okay? But again, the side effects can sometimes be worse than the initial problems, all right? Right, negative effects may be unknown. Pharmaceutical companies are hiding that stuff, that's for sure. Another version of biomedical therapy, in addition to psychopharmacology, is ECT, or electroconvulsive therapy. It used to be relatively common, and it's kind of scary because nobody exactly understands what's going on. But what would happen is ECT, people will, number one, they're given a sedative, okay, and to relax them, and then electrodes are attached to their body, and then big shock of electricity sends the body into convulsions, okay? And after the convulsions are over, the person is usually going to be passed out. And when they wake up an hour or so later, sometimes magic changes have happened, okay? Amazing changes. Now, ECT used to be used quite commonly for a variety of problems, but and in fact, if you've ever seen, and if you have any interest in psychology, you should everybody should watch the movie One Flew Over the Cuckoo's Nest. That was Ken Kesey's, based on Ken Kesey's book, where he had some experience in the psychiatric hospitals in the 60s and 70s, and it stars Jack Nicholson, so it's a pretty good movie. And what you can see quite clearly in that movie is that ECT was actually used by the hospitals as sort of a threat. It's like, if you don't behave, we're going to shock you. You know, it's got nothing to do with treatment. It's got to do with behavioral control of patients that are difficult to manage. Okay, and so the fact is that, yeah, However, they're very uncommonly used now, and it's almost exclusively used nowadays for depression. Okay, so this is again reserved for incredibly severe cases of depression. I mean, people that are just lying in bed all day long and just can't even get up the energy to go, do anything. And so what can happen is it can be a miracle. You can get this thing, you wake up, and it's like it just washed away. But what happens is you're inevitably going to lose about 1 week worth of memories, okay? A week's worth of memories. So clearly, even though we don't know what ECT does, it clearly disrupts neural pathways, okay? It really it seems to shuffle neurons around, for lack of a better word. It may break some of the neural connections that are creating the depressive symptoms, but it also breaks some of the neural connections involved in memories. And so, yeah, again, here I go, blending approaches to therapy, an eclectic approach. Yeah, there it is. I knew it would come away, huh? So there the specific schools that were at the origins of our psychotherapy are sort of disappearing, and people are sort of, let's look at each client as a unique person and put together in some way that puts it together. Here's an interesting dilemma, and it's a major concern of the American Psychological Association. Therapists bring judgments with them into therapy by definition. The biggest judgment they bring in is what equals psychologically healthy functioning. Okay, that's obviously the most, and so in a therapist's mind, they have a vision for what should my client look like when they're done. Okay? And that is, in fact, based on their cultural perspective of what equals psychologically healthy functioning. And I briefly mentioned that one before, that, in an independent cultural context, a 35-year-old unmarried male needs to be living with their parents in a collectivistic household. Needs to be. Psychologically healthy 35-year-old unmarried male must be living with their parents. Whereas from an independent perspective, that's got some real red flags. What? You're 35 living at home? Real red flags. And so the very definition of what is culturally healthy is clearly subjective. And so some people really argue that a therapist should never give therapy to anybody from a cultural group other than their own. And that becomes a real problem. Um, Looking for a therapist. Number one, you know that Texas Wesleyan has a counseling center. It's over on Rosedale and is 100% free for all Wesleyan students throughout time. Okay, so even after you've graduated, even if you've moved on, you can still come back and use the services for free. Now, we talked about, level of services from the bottom, pastoral counseling, to the top, psychiatry. The services at the Texas Wesleyan Counseling Center will be closer, far closer to a pastoral counseling than they will to a psychiatrist. So it is what it is, okay? Um, yeah, important to determine your comfort, etc. Okay. Cost, and we already talked about that. The insurance coverage and what they will cover will often guide what you do. You may well have a preference for a theoretical approach. You may think, oh, from a behavioral perspective, they're not treating anything, they're not getting at the underlying causes. Hey, that's on you, okay? Whatever you want to do. But keep in mind, therapy is often a slow process. It usually does not, in fact, involve a magical change. All right, so that's what I got here on psychotherapy, and in fact, that's what I got for this course. So get chopping away and studying on that exam 3, and we'll talk to you all later.